When you treat psoriatic arthritis and psoriasis, you have to consider multiple features about the patient. Treating psoriasis and psoriatic arthritis is a complex decision-making process. One thing that you have to know as a patient is that psoriasis and psoriatic arthritis are chronic and lifelong. We don't have a cure. No single treatment works for everyone. Switching treatments is common because the first treatment or even the second or third are ineffective. The fourth, though, may be quite effective. An important point is we never know right before we start therapy what the best therapy is. A lot of it is trial and error. Many treatment options are available, many of which are highly effective. So it's best that you listen to your dermatologist about all your options because they come in many shapes and sizes, so to speak. And sometimes patients need combinations of therapy, more than one modality. For example, light may be given with an internal medication like acitretin, Soriatane. Psoriasis treatment for localized disease, usually when it's less than 5% of the body. And as a rule, 1% of your body is the palm of your hand. If you have fewer than 5 palms of your hand of psoriasis, we often call you a mild patient. Not always, but usually, you're a mild patient. And in those instances, some patients don't need any therapy, or they need just topical therapies, or they might get phototherapy, ultraviolet light. Now, there are patients, though, who have widespread psoriasis, and generally that's more than 5% of the body. I don't like to strictly speak to percentages of the body when I talk about the severity of a person's psoriasis. I like to speak to how much does it affect them and to what extent does the psoriasis respond to topical therapy. Topical therapy is great for mild patients, but when it's ineffective, no matter what the body surface area, we have to turn to treatments for more widespread disease. And those would be, again, phototherapy, ultraviolet light. That could be UVB, narrowband or broadband. It could be PUVA. Then there's the traditional systemic agents, ones you take by mouth. For example, methotrexate, cyclosporin, and acitretin. And then the biologic therapies, and now there are currently 5 approved biologic therapies for psoriasis, and we'll get to those later. All of these are options for people with more widespread disease, and as I said earlier, a combination of the above may be necessary. When your doctor determines the treatment plan, they have to overcome quite a few issues. Some of the challenges are access to care. Some patients can't easily get to a dermatologist or a practitioner who offers all the therapies for psoriasis. It could be a geographic issue solely. Maybe you live 50 to 75 miles from the nearest dermatologist willing to treat you. The cost of care can be prohibitive to some patients, especially if you have inadequate private insurance. There are previous failures of treatment that bias patients, understandably. Our previous experiences with dermatologists that might have been negative that bias patients against going for more therapy. There may be side effects of previous drugs that were so negative that patients think all drugs and modalities are negative. That's not necessarily true, but it's an understandable perspective. There are other health conditions that might interfere with treatment. There may be issues of compliance on the part of the patient. In other words, they don't use their medicines as they should, and therefore they are ineffective in treating the psoriasis adequately. And then there are other features of the patient's lifestyle, for example, obesity and smoking and alcohol use, that truly inhibit effective therapy. The doctor has to consider issues such as the effectiveness of a therapy weighed against its potential side effects. And generally speaking, the drugs I'm speaking to today have a very good benefit to safety ratio, such that the safety issues are mild and rare relative to the treatment success rate. Types of psoriasis sometimes get different types of medicine. For example, we might treat inverse psoriasis different than pustular psoriasis. We have to examine how the therapies impact on quality of life and practicality. For example, light therapy, which requires often 3 visits a week to the phototherapy center or unit or office, is not practical for a busy person who can't drive 3 times a week to an office and take perhaps 30 minutes to an hour of their time. How easy is treatment? For example, topical therapies might be easy for localized psoriasis, but very difficult for widespread psoriasis. Injections may be a non-starter for some people. And then finally, insurance issues. Are the drugs paid for by the insurance plans that the patient utilizes? And FDA approval. Insurance will not pay for a drug often if it isn't approved for the treatment of psoriasis. Luckily, all the modalities I'm speaking to today are pretty much approved by the FDA and therefore can be delivered to patients with more severe or mild psoriasis. It's good to know that drug companies are still looking at new therapies for psoriasis. So we have a long list now of available therapies, and that list is growing year by year, both in the topical therapy realm and in the biologics realm, and in the small molecule oral drug realm. And hundreds of trials, I should say, are ongoing, and many drugs are being investigated, many of which will never make it to FDA approval, but it's a numbers game. The more that are being evaluated, the more likely 1 or 2 will succeed and be good options long run. Some of the more promising drugs in the pipeline are new TNF-alpha blockers. Just to be clear, we already have 3 TNF-alpha blockers that are approved for psoriasis and psoriatic arthritis. They are etanercept, which is Enbrel, adalimumab, which is Humira, and infliximab, which is Remicade. There are 2 new ones, or I should say newer ones, in the pipeline, one called golimumab and another one called certolizumab. Whether these 2 drugs will ever be psoriasis drugs and not just psoriatic arthritis drugs is left to be determined. And then, as this slide shows, there are inhibitors of IL-12 and 23. There are 2 drugs in the pipeline, ustekinumab and ABT-874. It appears that ustekinumab will have the trade name Stelara and will be the first to be approved sometime in 2009. Both of these are highly promising medicines that work very often and require fewer administrative injections for the patient. To be continued. Now let's talk about your general health. In general, we have to consider your health when treating psoriasis because not all drugs are appropriate for everyone. As I said at the beginning of the talk, psoriasis is not simply a skin condition. It's associated with inflammation of other organs and tissues in your body. And this is probably the least understood aspect of the disease, and many dermatologists don't talk about this with their patients. For example, beyond the joints, which I went into detail, there's an increased risk of heart attack in all likelihood for people with more severe psoriasis. In other words, if you're between the age of 20 and 65 and have more severe psoriasis, that in and of itself may increase your risk for having a heart attack in your lifetime when compared to people who don't have psoriasis that's severe, or just people without psoriasis. People with psoriasis probably have a higher risk of diabetes. They also have higher rates of depression. They are much more likely to be overweight or obese. They much more likely have inflammatory bowel disease. And importantly, they have higher rates of certain types of cancers, specifically lymphoma. So we must remember when we're talking about lymphoma that the psoriasis, the condition itself, is what's causing the increased rate of lymphoma. and not necessarily the medications being used for psoriasis. Keeping in mind that psoriasis affects a variety of other health issues, the National Psoriasis Foundation's medical board, of which I'm a part, has made a list of recommendations for people with psoriasis to optimize their health, to reduce the chance of other diseases affecting them negatively, and importantly, to increase the chance of treatment success. For example, quit smoking, drink alcohol in moderation, eat a healthy diet, exercise 3 times a week for at least 30 minutes, have screening tests for cardiovascular disease very early in your life, earlier than another patient who might not have psoriasis. And by that I mean go to your internist or primary care physician, make sure your cholesterol level and triglyceride levels are monitored, have your blood pressure checked, make sure you don't have diabetes, and be counseled appropriately about keeping your weight down. Finally, if you have depression, or you think you might have symptoms of depression, have this addressed by a qualified physician who may institute therapy. What I'm trying to say is psoriasis is a disease that goes beyond the skin, and a more holistic approach must be taken to adequately treat the patient and increase their quality of life.